Good afternoon, everyone, and welcome to this inaugural webinar for the Andrology Research Academy, AReA. And what we're going to talk about today are the implications of low testosterone in patients with COVID-19. So I am Professor Hugh Jones. I'm a consultant physician, endocrinologist and diabetologist in the United Kingdom, in England. I'm based in Barnsley, which is just a town which is just north of Sheffield, and I'm at the University of Sheffield as well. Here are my declarations of funding. I've received research monies and Congress attendance, advisory board attendance and speaking honoraria from Bezoar, Bayer, Mereo Biopharma and Medac Pharma. So what is the aim of the AReA platform? AReA is a new educational platform that will provide a forum for educational exchange, share the latest research in the field of andrology, and foster interaction with international experts. Bezoar Healthcare is the sponsor of this site and is committed to continuous medical education to ensure that physicians have the most up-to-date knowledge and can make the best treatment choices for their patients. This webinar will have the objective of introducing and appraising the existing evidence base for the relationship between testosterone deficiency and hospitalization, and review the newly published data on low testosterone in patients with COVID-19. It will also increase your knowledge and understanding of the implications of low testosterone in the COVID-19 patient population. So I'm the chair, and shortly I'll be handing over to the first speaker, who is Professor Linda Vignosi, who is Associate Professor of Endocrinology at the Department of Experimental and Clinical Biomedical Sciences at the University of Florence. And she will be followed by Dr. Mary Samplaski, who is Associate Professor of Urology and Director of the Male Infertility, Andrology and Microsurgery Unit at the Institute of Urology, University of Southern California. And then at the end, we'll have 15 minutes for discussion and questions. So you have the ability to add questions to the site, and hopefully yours will be answered. But if we have a lot of questions, we'll have to pick out those key questions which would be of interest to the audience. So we know that COVID-19 has a predilection for increased severity of infection and mortality in men compared with women. And this slide was produced early on in July and shows that this is consistent between many countries throughout the world, so including Peru, South America, Italy, Spain, England, France, the USA and Mexico, although the difference was not too great in Sweden. But we still know from studies that are being published that men have greater risk of developing the infection and also have a worse outcome as well. We know in men, low testosterone is associated with a lot of comorbidities, and these are very common comorbidities, including cardiovascular disease, type 2 diabetes and metabolic syndrome, where these conditions can amount to 40% of their population having the condition. Cancers, COPD and respiratory diseases. Men with low testosterone have an increased risk of osteoporosis and fracture, which may be due to low trauma, rheumatoid arthritis and other autoimmune arthropathies, HIV, which is of great interest to several different units, chronic kidney disease and hemodialysis, myopathies, including dystrophia myotonica, and we were taught at medical school that hypogonadism was a feature of dystrophia myotonica, depression, and in particular erectile dysfunction, which may be a manifestation of testosterone deficiency. So does testosterone play a role in COVID-19 disease, susceptibility and severity? So is normal testosterone status important for innate immunity? Is testosterone protective, or does it increase the risk of infections? Also, does testosterone play a role in the severity? Does suppression of testosterone levels by the infection lead to an increased severity of the disease? Or is it the severity of the infection which suppresses testosterone production? Could and should testosterone be used clinically as a marker of the degree of infection? Or is there something else about being male that leads to this increased predisposition for COVID-19, infection susceptibility, severity, and mortality rates? So that's what we want to find out, if there's any information today. And we will start off the meeting with Dr. Vignosi talking about her research. Thank you.
Thank you, Professor John, for this very nice introduction and for introducing this very hot topic. I will present, this is my disclosure, this afternoon I will present the results of our study designed and conducted during the first wave of COVID pandemic, demonstrating for the first time that lower testosterone level at the baseline predicts poor prognosis and mortality in SARS-CoV-2 infected men. So we decided to enroll with the participation of also the University of Mantua, which was in the very red area for infection of SARS-CoV-2 patients. And so we enrolled 31 men and followed them for their clinical outcome after their admission to the respiratory intensive care unit. And so we monitor them and we follow for their outcome, their clinical outcome, if they were maintained in the respiratory intensive care unit or if they were transferred to a lower intensive care within the internal medicine unit or transferred to with a worsening of the clinical symptoms to the intensive care unit or deceased. And these are the main demographic and baseline medical parameters of these patients, subdivided according to their clinical outcomes. And the major differences that we found were related to the percentage, for example, of acute respiratory distress syndrome and some inflammatory parameters such as neutrophils and with a reduction, for example, lymphocyte, which is a very typical sign of SARS-CoV-2 infection. Then we have also an increase of procalcitonin and LDH and fibrinogen in patients who show a worsening of their clinical outcome with a transfer to ICU, so the higher intensive care unit or deceased. And so these inflammatory parameters correlated with the worst prognosis and the worst clinical outcome. In this patient, we saw in patients who were transferred to the intensive care unit or deceased, we also observe a dramatic reduction of testosterone level, of total testosterone level, but also a dramatic reduction of calculated free testosterone level and a parallel increase, a sustained increase of LH. So this was a very clear biochemical and hormonal picture, and here is the same data, but we stratified also and subdivided also patient in the intensive care unit or deceased in order to see the progressive decline of total testosterone level with the worsening of the clinical outcome of calculated free testosterone level show exactly the same progression and a stable increase of LH. And so the first question was just to see if there was something very similar also in other hospitalized patients. And so we look in the literature, but it seems that what we observed was a specific effect of SARS-CoV-2 infection. So low testosterone level associated with a normal or high LH level in the patients who show a worsening of their clinical outcome. And indeed, in this, for example, in a previous study enrolling hospitalized patients with acute myocardial infection, was observed was a reduction of testosterone, which was associated with a reduction respect to the baseline of LH levels. So a reduction of testosterone, reduction of gonadotropins. The same data were also obtained in other small cohort of male subjects with critical illness requiring intensive therapy, and exactly the same. There was a reduction of testosterone, and who were discharged were observed an increase of testosterone, while patients who were remained in an intensive care unit show a progressive reduction of testosterone with a progressive increase of LH. And indeed, this was our first result that we published immediately in May 2020. Another paper published the same results, the same picture, with a reduction of total testosterone level and a parallel increase of LH as compared to age-matched control in patients with in 119 SARS-CoV-2 infected male subjects. And the reason why, so taken together, first of all, this data suggests that a primary hypogonadism is a specific feature of SARS-CoV-2 infection. And so, indeed, the expression of pivotal and very important markers and target for SARS-CoV-2 infection were expressed in the testes, and with AC2 mainly expressed in sertoli and Leydig cells, so also in the cells that are important for production of testosterone. And in our cohort, indeed, we observed that we were able to find a clear cutoff for testosterone level. So testosterone level below 5 nanomolar was associated with a sharp and a very clear-cut increase of LDH or procalcitonin and ferritin, which were three very important inflammatory markers associated with mortality of SARS-CoV-2 infection. And so exactly the same picture was also observed with a calculated free testosterone below 100 picomolar. So we were able to find some cutoff was associated with a worsening of the clinical outcome. And indeed, we were able also to observe that the total reduction, a decrease of total testosterone level of 1 nanomolar, or a reduction of 10 picomolar of testosterone was associated with a relative increase of the risk of worsening of the clinical outcomes, with respectively as a factor of 42 or 25% respectively. And the probability, for example, to be transferred to an internal medicine, so to recover and to improve the clinical sign, was 95% in patients with total testosterone above 5 nanomolar, where we observe also a very, very low probability of mortality or transfer to a higher intensive care unit, 0.6 or 0.4%. And so we observe that, on the contrary, with a low testosterone level below 5 nanomolar, we observe a higher probability of being transferred to ICU or to disease. And indeed, what we also we observe the same data represented in this very nice picture, with 5 nanomolar and 100 picomolar as the main cutoff for this worsening or improving clinical outcome. And on the other hand, so in summary, this very first study evaluating testosterone in SARS-CoV-2 two infected men admitted to respiratory intensive care unit, we were able to demonstrate that the higher value of LH along with the lower total testosterone level or calculated free testosterone level were found in the transferred to ICU or deceased patients in respiratory intensive care group. And so this was correlated. We were able to find the total testosterone level and calculated free testosterone level show a very negative correlation with all the biochemical factors that are correlated with the worsening of the disease, so the neutrophil count, LDH, or procalcitonin level. But a positive correlation, for example, with the lymphocyte count, which was associated with an improvement of the clinical condition, and we have a lot of evidence in the literature about this. So testosterone level also correlated with other important inflammatory markers such as SCRP or ferritin, and the most important things was that we were able to find a cutoff and to find that for testosterone level below 5 nanomolar or calculated free testosterone level below 100 picomolar, we were able to find a steep increase of both ICU transfer or mortality risk in this population. So this data proposed to measure total testosterone level, calculated free testosterone level, because lower baseline level of this hormone can predict poor prognosis and mortality in male subject infected by SARS-CoV-2 viruses. So we need, our concept is that we need to study this very important relationship between hypogonadism and testosterone level with this severe respiratory infection, and which is to be very specific and very different from other infections which are normally correlated with low testosterone level associated with low LH level. This disease is associated with low testosterone level and sustained and increased LH level. So it's very specific, and we need to study perfectly this relationship just to understand the full interaction. So the final slide is to acknowledge all the co-authors and collaborators. First of all, Professor Maggi from my university, my mentor, who has the idea to measure testosterone in this subject, and Professor Lenzi, Professor Giovanni Corona, and all the staff from the University of Mantua and from the University of Milan with Andrea Salonia, who were deeply involved in this study. Thank you all for your attention.
Okay, right. So with that difficulty, we will pass to Professor Mary Samplaski, who's going to talk further on the role of testosterone in COVID-19 and infections. Thank you.
Well, I'd like to thank the Andrology Research Academy for inviting me. I think these are two very poignant and timely topics. Certainly COVID-19 is affecting literally the entire world, and testosterone replacement is a very sort of hot topic. There's a lot of patients that come asking about these therapies. And so I think intersecting those two Venn diagrams and finding out if testosterone may actually be able to improve outcomes in COVID patients is a huge opportunity to improve our care of these patients. So thank you to the speakers for this very kind and honorable invitation. I have received funding from Besans as a speaker. So we know, as Dr. Jones alluded to, that COVID does affect persons of advancing age with more frequency and with more severity. This is data from the U.S. Centers for Disease Control, and it basically shows that with increasing age, there is increasing hospitalizations, ICU admissions, and deaths. And for persons that are less than 54, this is estimated death rate of about less than 1%. But the number slowly increases. And for those over 85 years, it ranges from about 10 to 20%, 10 to 27% of patients that will potentially die from COVID. So certainly that is a large number. We also know that males tend to fare worse when they are affected by COVID. So early data from China reported that about 60%, that males accounted for about 60% of COVID-19 patients. But then what did become fairly clear as the data emerged from different countries was that COVID seemed to affect males more severely. So more ICU admissions from Chinese data, 67% of ICU admissions, and then about double the fatality rates. And as data emerged from Europe, this also seemed to be the same sort of pattern, about double the ICU admissions and double the fatalities. And American data shows that males also account for about 60% of COVID-related deaths. So I think it's pretty sort of consistent that there is some type of gender predisposition for COVID-19, with males being more severely affected and accounting for more of the deaths. So what is hypogonadism? In the lay literature, this is often referred to as menopause or andropause. Certainly this is sort of from a lay press perspective, thought to mirror menopause. But this is low testosterone associated with symptoms. We started to see this around 40 or around age 50, although certainly you can see it a little bit sooner, and then there are people who you don't see it until later. Symptom-wise, the most common symptoms are impaired libido, erectile dysfunction, but there are a lot of other non-specific symptoms that patients can endorse, including impaired low muscle mass. People say, I go to the gym and I can't work out as long, or I can't lift as much. I've had people report brain fog, and just sort of overall impaired vitality. And this graph shows the age-related decline of testosterone that we see in our patients. We estimate that it declines at about 1% per year, again, starting somewhere in the mid-40s, early 50s. This rate is not completely consistent, and there's a variety of other factors that can impact this rate of decline, including medications, underlying testicular infections, diseases, cancers, chemotherapies, emotional stressors. So this isn't a completely hard and fast decline, but in general, what I tell patients is it does seem to be a very slow and steady decline. I think unique to testosterone is that the symptoms that guys experience are not necessarily completely unique to testosterone replacement or the hypogonadism. So low energy is very nonspecific. You can see that with other conditions such as vitamin deficiencies, diabetes, thyroid issues, anemia. And so you have to sort of tease out what is the underlying cause. And the term hypogonadism or androgen deficiency from a clinical perspective is low testosterone from American guidelines defined as less than 300 nanograms per deciliter plus symptoms. And this number of patients who meet these criteria does increase with age. And interestingly, not all of these men will receive treatment. I think this number is sort of a moving target. There certainly were some concerns about testosterone replacement safety that I think with most recent literature and data have now been sort of shown that this therapy is safe in a monitored setting, but not all these guys will receive treatment. This is data from the SHORE study, or the VA Puget Sound study. which I'm sure many of our viewers have seen, it shows that the lowest levels of testosterone have also been correlated with the highest levels of mortality. So this is not just a therapy or a condition that is associated with quality of life, like erection quality. This is associated with overall mortality, real sort of long-term health outcomes. So there is a correlation between low testosterone, frailty, and mortality. And overall mortality is more pronounced in men, older men with metabolic syndromes. And older age certainly is associated with a host of comorbidities in and of itself, including metabolic syndromes, obesity, diabetes, and these can also correlate with hypogonadism. And these conditions themselves can predispose to diseases and mortality. So certainly patients who have underlying diabetes, we know that they're at a higher risk for multiple other downstream issues. But certainly there's data that men who have prostate cancer who are given androgen deprivation will develop some type of metabolic syndrome. And conversely, hypogonadal men who are treated with testosterone replacement have been shown to have improved insulin resistance, improved obesity outcomes, and improvements in dyslipidemias. And what can be difficult to know which sort of came first, the chicken or the egg sort of dogma, but certainly these conditions often coexist and ultimately are associated with slightly more adverse health outcomes. So testosterone replacement therapy is the only FDA-approved treatment for male hypogonadism. And what I tell patients is reassuringly, we now have great sort of guidelines for what is the criteria for testosterone replacement, what are our target testosterone values on replacement, what are the associated risks, how should these guys be managed, and what are our target goals. And so in my personal opinion, as long as clinicians follow the guidelines, these replacements are generally considered safe. So taking a step back, with aging, there is a progressive decline in immune system function and a generalized remodeling of the immune system. So there's a baseline increase in systemic inflammation, including an increase in IL-6 and tumor necrosis factor alpha. This results in an decreased ability to respond to immune challenges, and when patients do get sick, an increased risk of adverse infectious outcomes. Specifically, for some specific conditions, males over 65 account for more than 70% of influenza-related deaths. Males are more likely than females to be hospitalized and succumb. And we know that sex steroids, including testosterone, can impact the inflammatory and immune response. Testosterone acts on androgen receptors in immune cells, specifically macrophages and T cells, resulting in suppressed immune function. So testosterone, when it's given to hypogonadal men, can protect against immune inflammation-mediated diseases. Certainly, we know that low testosterone is associated with higher rates of infection-related hospitalizations and all-cause mortality in male hemodialysis patients, and similarly in influenza patients. And interestingly, when hypogonadal mice with pulmonary infections were treated with testosterone replacement, these mice fared better with reduced morbidity and mortality independent of the viral replication loads or pulmonary inflammation. And in humans who are given the influenza vaccination, males tend to develop a lesser antibody response than females, which makes us wonder, does testosterone play a role in these outcomes? IL-6 is a characteristic biomarker seen in COVID-19 patients. It's a pro-inflammatory cytokine, which is upregulated with stress, inflammations, and infections. And we know that when patients with COVID-19 are given IL-6 receptor antibodies, particularly when they're more in the severe stages of the disease, these patients will have improved outcomes. And the Society for Immunotherapy of Cancer actually encourages the use of IL-6 receptor blocker antibodies for pro-inflammatory conditions seen in many cancers. And so we know that these IL-6 blockers may mediate malignant pro-inflammatory conditions. And certainly we've seen this in COVID patients. So having those two Venn diagrams sort of overlap. IL-6 is elevated in hypogonadism, even without stress, even without inflammation, even without infection. With hypogonadal states, you will see a baseline increase in this pro-inflammatory cytokine. And when you give hypogonadal men testosterone, IL-6 is downregulated. So there's a reduction in the inflammation and an improvement in adverse health outcomes. And this appears to be independent of the underlying condition. And in fact, testosterone replacement therapy has been more effective in mediating this inflammation in hypogonadal as opposed to eugonadal conditions. And it's also been shown to have similar effects in TNF-alpha, another inflammatory cytokine, suggesting that testosterone may attenuate the inflammatory process on multiple fronts. And I think the take-home message from this slide is just that, in general, testosterone does protect against inflammation. So we know that about 50% of admitted COVID-19 patients will develop ARDS. And certainly this is a moving target as we learn how to better treat this disease. Hopefully this number will continue to decline. But this is a large proportion of patients who develop COVID-19 who are admitted. And patients who develop ARDS, this is a sort of poor clinical prognostic factor. About half of these patients will potentially die, and elderly patients are more likely to develop ARDS. And we know that critical illnesses progress in two steps. There's the acute phase, which happens in hours to days, and then there's the chronic phase, which is days to weeks. In the acute phase, there is a decline in testosterone that is seen, and this does continue into the chronic phase. And interestingly, this seems to be independent of LH, indicating some degree of hypothalamic pituitary gonadal dysfunction. So we know that about half of males over 65 with ARDS, when you check their testosterone, it will be low. And this testosterone level correlates with mortality, and it's also correlated with higher IL-6 levels. And with this information, I think the sort of hypothesis and a current research question is just, does hypogonadism create some type of a permissive environment for severe ARDS outcomes in men? And certainly, testosterone is among the medications that has been shown to attenuate the catabolic response in critical illnesses. And low testosterone is part of the pro-inflammatory profile associated with ARDS. And testosterone replacement has been shown to reduce airway inflammation in patients with asthma. So just taking a step back, is the testis a COVID-19 target? And I think the jury is still out in sort of many of the outcomes related to this, but certainly COVID binds to the ACE2 receptor, which acts as the viral receptor. ACE2 is seen in the testis. It's also seen in the lung, heart, kidney, bronchus, and via the spike protein. I think, from a theoretical perspective, the spike protein plus ACE2 can serve as a vector for which COVID could potentially enter the testis. And we also know that the testis is a target for other viruses. So SARS, Zika, Ebola, all of these have been shown to be targets for viruses that can affect the testicle. These can result in a range of adverse testicular outcomes. I think the most probably mild is orchitis, which is generally manageable, but then they can also result in low sperm counts, hypogonadism, and testicular tumors. And I'd say this is a question that I get asked almost every day in clinic. Will COVID-19 be transmitted in my semen? And we just don't know the answer to this question yet. Certainly, I think the life and death nature of COVID sometimes makes the transmission from semen take a little bit of a back burner. But I think as more and more of these cases accumulate and patients do better in terms of outcomes, we do need answers to these questions. Early German data looking at COVID in the semen of men who were either acutely infected or had recovered did not show that there was any COVID-19 in the semen. Chinese data did show that in a small percentage, about 20% of guys, they did find COVID in the ejaculate. And there was a bit of a different follow-up. The German data was slightly longer follow-up at 43 days versus 6 to 16 days in the Chinese data. But I think we just don't know the answer to this question yet. But in summary, I think it's very clear that COVID seems to affect males more than females, and certainly older people less than younger people. It's possible that low testosterone may facilitate the severity of COVID-19 infections, and IL-6 seems to be the vector by which this may happen. Testis may be a target organ for COVID-19. And I think the questions, it's possible that testosterone levels may offer some type of protection from COVID-19. And the questions moving forward in learning how to optimally care for these patients, should we be checking baseline gonadotrophin levels? Should we check FSH and LH in these patients? Should we be checking and following their testosterone levels? Should we consider treating them with testosterone replacement therapy to bring them to a eugonadal number? And does doing this improve their COVID-19 outcomes? And then long-term, once these patients have recovered from their acute COVID infections, does this infection result in short and long-term reproductive functional impairments? So I'd like to thank the committee for inviting me to speak. Certainly the other speakers, I stand among giants, Dr. Jones and Dr. Vignosi. And I will return the sort of platform to Professor Jones. Thank you very much.
Right, thank you very much for those two talks. That's excellent. Dr. Vignosi will take questions and answers now. She'd almost completed her talk, but unfortunately technology outweighed things. So I'm going to ask some questions. I'm obviously done a lot of work before on inflammation in illness, cardiovascular disease, and I am impressed by the fact you've got to have inflammation before testosterone seems to have an effect to suppress it. And if there isn't inflammation there, it doesn't seem to have that action. So should testosterone be considered as a marker of inflammation? Now, Dr. Vignosi, you've actually answered that to a degree, but how do we convince physicians and ICU consultants to measure testosterone in the clinical state, in the situation? Because obviously this is one study, and it seems to be quite powerful and clearly has potential for being a major role in the management of these patients. So how should we progress?
Okay, thank you, Professor Jones, for this question that give me the possibility to a bit expand the concept. So we studied the role of hypogonadism and testosterone level in many other inflammatory diseases. This is the most acute one that we and a very severe and viral one that we studied. but actually we observe the same reduced testosterone level in several other, also chronic with a low level of inflammation, such as obesity and metabolic syndrome conditions. So low testosterone seems to be one of the parameters, the clinical parameters of chronic inflammation, and it worsens. So testosterone level is not only a sign, but also something that worsens the inflammatory condition. So testosterone is able, and literature is plenty of evidence that testosterone can counteract inflammation and can help in fighting inflammation. So in this particular disease, we suggest to measure testosterone, since it could be prognostic. So it is very important to find prognostic and markers for helping the physician to understand who is in front of them and who will be the outcome, the probable and the most potential outcome, most prevalent outcome of this subject. So, I mean, it could be very interesting to measure testosterone in this patient, just to have something that help in stratifying the patient with a high risk or with a moderate risk of worsening. So, actually, we do not have such an amount of parameter to predict the prognosis. So in this sense, testosterone can be one. And we have to be very cautious to translate with the testosterone replacement therapy in this subject. But I mean, we perfectly know that we are replacing something and not treating and using an overtreatment. So this subject has extremely low level of testosterone, and so we would like to plan a clinical trial just to measure, also in observational study, what happened treating testosterone with testosterone in this patient. So it could be very, very important to see. And the last slide that I unfortunately was not able to present, but published data, so are in female, and in female are exactly the opposite. So we measure testosterone. Testosterone was not correlate with the progression of the disease. And in our mind, this is something that can help the management of male subject, and we should that have also the worst clinical scenario and the worst clinical outcome. So we need for parameter to be measured and to use for the prognosis. So.
Thank you. I've got one question here. It said, might it be possible that the poor prognosis resulted from the comorbidities and not just from low T? So, Professor Samklaski, have you got any views on that?
I think it is all sort of there's many factors at play. Like none of these factors are sort of working in a vacuum, and so I think yes, probably underlying comorbidities certainly probably do play a role, and it's so hard to tease out, you know, what is the contribution of one factor versus another, and that's why I think Dr. Vignosi's work is so important, because she actually does a very nice job of teasing out those different factors. But it's hard to know what is the relative contribution of one comorbidity to another. But I think from a clinical management perspective, what we're always trying to do with these patients is sort of, the phrase we always use is put all our ducks in a row. So stack as many things in their favor. And if, you know, optimizing the testosterone is one factor that even is part of the puzzle in terms of providing the best care to these patients, I think, you know, it's something that we should look into. But, Yeah, I mean, none of these factors are working in isolation, and so the underlying comorbidities could be playing a variable amount of role.
One question which might extend that: androgen deprivation therapy for prostatic cancer. Have you heard of any increased risk of these patients who have really quite low testosterone levels having a higher risk of developing COVID-19?
I have wondered this exact thing. I actually searched. I'm not there. To my knowledge, there are no publications looking at that exact population. But I think, as sad as that there are so many cases of COVID, I will be very curious to see if that condition in particular is something that we induce a hypogonadal state. If those patients develop COVID with a higher frequency, or if they fare any different in terms of their course. I personally have not had any patients, but I think, to be fair, my practice is a little bit more comprised of testosterone replacement. I don't do I don't do any prostate cancer management. So I think I see a skewed population. I see people who do not have prostate cancer who want to go on testosterone replacement, but it's a question I'm very curious about myself.
Thank you. There's another question here. Should public health policy around COVID better recognize hypogonadism as a risk factor for severe disease, i.e. should known low T patients be better protected? Linda, would you like to answer that question?
Yeah, I perfectly agree with this concept. So we need to stress and to improve our knowledge on this topic, but the evidence that we have right now seems to suggest that we should measure testosterone just to have an additional parameter to predict, and to also to monitor in a different way patients who are at home with COVID-19. And so with low testosterone level, most probably we should have a more careful monitor and a more careful evaluation of their progression, because it seems that they could be more prone and more able to have a worsening. So I mean, I think that we found something that could help in facing this very dramatic and dreadful pandemic that we know in so little, and we know very few things about this very severe infection. So we need to study, and we found something that was very, intriguing and very, very promising. So I think we should continue to study the role of testosterone and hypogonadism in this infection.
Right, thank you very much. There's a next question. What is, to Mary, what is the reason, except of science, of measuring testosterone in that state? There is no evidence for testosterone replacement therapy of influence, and it is not a clear prognostic parameter. So is there any basis for measuring testosterone? I think we've seen a basis, and I would add a supplementary question to that as to whether those men who are already on testosterone replacement therapy should continue their therapy in hospital. Because one of the problems we've had in the UK is that our general practice have also sort of closed down on injections, and the people are not getting their testosterone intramuscular injections. And that might increase risk, we don't know. So what are your thoughts on continuing management, and also the original question about measuring testosterone?
I have encountered some of the same challenges, and it's actually, it's sort of nice to hear that even from the European side that some of the same challenges are happening. But I've had patients who, they're admitted and they don't get their testosterone replacement, and I do wonder if that is making that dramatic of a change a good idea when they're already sort of fighting a pro-inflammatory state. But I think from an American perspective, this often just boils down to how comfortable certain groups of physicians feel with the safety of testosterone replacement. From my perspective, I'm a urologist. We have clear guidelines for testosterone replacement and sort of what is a safe way to manage these patients. But I have, I've had patients who are not put on their testosterone replacement, and I have sort of asked to have this given, and sometimes some of the treating physicians are a little gun shy to do this. I do wonder if that is doing the patients a disservice. And I'd say to the other question that was at the very sort of beginning of the question that you gave to me, lack of evidence does not necessarily imply a lack of efficacy. So just because there's not studies looking at taking guys in similarly paired groups of men and having half of them on testosterone replacement and half not, does not mean that effect doesn't exist. It just means that we don't know. And I think that would be such a valuable data set to have. I like I said, I worry about my patients who are admitted who are not put on their testosterone replacement, because are we sort of hurting their outcomes? And I don't think we know the answer to that question, but it worries me.
Yeah, I agree. I've seen patients who have had testosterone replacement therapy and have come back feeling better in regard to their autoimmune disease. I had one man, for example, he didn't tell me initially. I put him on testosterone and he'd been on it for about a year, and he said since he'd been on it, he'd not had any alopecia areata, which had been troublesome for many, many years. And you see these nice sort of anecdotes, if you like, and there were studies many years ago which showed that patients with Klinefelters presented with systemic lupus erythematosus, SLE, and they were given testosterone, and while their SLE was being worked up, their SLE improved on testosterone replacement therapy. So there are some evidence that it can have benefit. So we have another question. Do you recommend that low testosterone males with COVID-19 should be put on testosterone replacement therapy or boost of testosterone during the acute phase of inspection? I would actually know what your answer is going to be, but if you could answer this question for this person who's asked it.
I come from the sort of what I would. We always have sort of multidisciplinary approach. I personally, again, tend to practice a very guideline-based medicine. So per American Urology Association guidelines of management of testosterone deficiency, yes, if somebody came in and their testosterone was, we'll say 150 nanograms per deciliter, I think for most Europeans that would be like 1.5. I would probably recommend that they go on some type of testosterone replacement therapy with a target testosterone of 500, but that's guideline based. I think I watch my patients pretty closely in terms of numbers. We don't want people to have testosterones of like 1,200 in a consistent way, but I think the data is showing that testosterone will sort of mitigate the inflammatory response is very consistent. And we do know that in COVID that the inflammatory component is a big part of how the patients fare. So I think in answer to your question, yes, I would recommend that they go on testosterone replacement. I do think we watch their numbers carefully and multidisciplinary approach, but that's what I think the data shows.
All right, so do we have another question? Yes. No, we don't have any more questions online at the moment. I would ask, do you think testosterone has a role in suppression of the cytokine storm? Because that's one of the key things that seems to set off in these severe infections, that there's an uncontrolled cytokine response, which then acts fighting off the own tissues of the body and probably accelerating the ARDS. So we know dexamethasone, which is a steroid, may have an effect. testosterone is a steroid, and you wonder whether or not that has an effect. And there is good evidence from both laboratory work and also the clinical studies, which some of you have shown, that the pro-inflammatory cytokines can actually suppress interleukin-6, tumor necrosis factor alpha, and IL-1. And I've also seen it in studies show an increase in the anti-inflammatory cytokine interleukin-10. So Linda's back with us now. So would you like to comment on that if your microphone works?
Yeah. Can you hear me? Yeah. Okay,
Yes,
so I agree with this view. So, I mean, evidence in the literature are clearly identifying testosterone as a normal able to balance between the Th1 and Th2 response. So we perfectly know that the Th1 is the most severe and also the inflammatory response, which is able to maintain the inflammation and to maintain and to worsen the inflammation. On the other hand, Th2 is able to counteract the inflammatory disease and to shut down the inflammation, to resolve inflammation. And in a lot of other inflammatory disease, testosterone has been demonstrated to reduce Th1 cytokines and to increase LH10 cytokines, which is a Th2 cytokine. So, I mean, the anti-inflammatory one. So, a lot of evidence are telling us that testosterone is able to balance the inflammatory response. And in this sense, I think that it could be able to block also the cytokines storms during SARS-CoV-2 infection. It could be. I mean, we have to clearly measure and study this phenomenon. So, I mean, we have to study, but it makes sense.
Okay, we don't have any more questions that have come through at the moment, so we've completed those questions. So the questions that really, we've got this difference with COVID-19 that it causes an increase in LH and FSH due to what is a primary hypogonadism, whereas all the other acute illnesses, the 4 I's, if you like, infection, infarction, injury, and inflammation, all cause suppression of LH and FSH. Now, LH and FSH are key markers of systemic inflammation. So we have a different response here. So do you think that why is the primary hypogonadism the overarching feature of COVID-19 when you would expect with cytokine production you should get LH and FSH also doing? So you should have a mixed picture. But from your evidence, Professor Vignosi, we don't seem to have that issue.
Yeah, so it seems to be very specific of SARS-CoV-2 infection, and this could probably do, but we have to evaluate it, that this virus can infect also Leydig cells and reduce the production of testosterone by the Leydig cells. So it seems that AC2, as I show you, is expressed in the cells, and so it could be one of the reasons why we have this very specific and peculiar hypergonadotropic hypogonadism. So it's very different from the other critical illness, and it seems that the test is suffering in this condition. So we decided to also to improve this type of study, and we are measuring and monitoring all these subjects just before the recovery, and to see if the LH could reduce with an increase of testosterone immediately after the recovery from infection. But we are studying it just to know something more about this very specific picture of this infection.
Thank you. Right, so there's another question that's come through, What is the additional risk of low testosterone in COVID patients relative to other well-known risk factors? Is there enough data to benchmark this? So, Professor Samplaski, any ideas to respond to that question?
I think it's difficult to answer the question because we just don't have a whole lot of data looking at does testosterone replacement in these patients improve their outcomes. I think what has happened in these patients is that we are trying to sort of put all of the things, sort of stack the odds in their favor, and so giving them steroids just sort of decreases the immune response. And so if we giving them testosterone, I think should also mitigate that. But I think in the absence of data, it's hard to know the exact sort of proportion that testosterone would play or does play in the sort of individual patients or even global patient response to COVID infections. I just don't think we have enough data to answer that question.
Mm-hmm. So, yeah, I mean, when you consider COVID's only been around a few months, really, there's a lot of data that's coming out, but clearly much more needs to be done. I don't know about, we're kicking off with a second wave here in the UK, and my area's gone into tier 3, which is the highest tier, where we're almost in a lockdown again, going in from this weekend. So cases are starting to increase quite dramatically here as they are in Italy, I think.
It's the same thing.
Yeah, so it's
the same scenario. So I mean, and the very peculiar thing is that the same region has the same wave. So we have a regional difference here, and the same region has the same very severe disease. So I mean, there is something that is still to be studied, and we need to study very, very deeply.
Yeah, the important thing is there's a lot of factors going on, and testosterone may be one. It's what is the value of each factor in the whole picture of COVID, and hopefully things will be sorted out to help treatments. So I think we're coming to the end of the session now. I think thank you very much to both the speakers. It's been an interesting event, and hopefully the audience have enjoyed this and have started to think about things testosterone wise in their patients. So hopefully the next time we talk about COVID, we'll have a bit more information and be able to give a bit more guidance. But there definitely seems to be a potential role in the measurement of testosterone, as this can be a prognostic marker within the hospital. So I think we should get our hospital to try and do this and see what results we get as individual centres. So thank you very much for the lectures, and thank you very much for the audience and their participation, and I'll close the session. So thank you very much indeed. And thanks to Besom for supporting this, and hopefully there'll be many sessions in the future from Besom which will educate the medical fraternity about testosterone and its merits. Thank you. Good night.